Hey, David Kleiman here with the EMS division. Today I'm here with Dr. Eric Nix. Doc, thank you so much for coming today. I really appreciate you coming out.
Thank you for having me. Good morning, guys. Good afternoon or good evening, whatever time it is that you're watching this. I'm glad you can join us. We have a couple of modules coming up for you guys. We're going to talk about a clinical update first. First of all, double sequential defibrillation. We produced a video on that last year. There was a temporary pause before we implemented that. We're looking to implement that going forward, so if you guys could watch that, that would be awesome. If you have any questions, definitely reach out to me or reach out to David, and we can help answer that, and we'll try to get you training on that. The reason for that, there's about 3 times better rates of resuscitation for survival to discharge, so it's very important that we implement this to get better outcomes.
And on the double sequential, right? Correct me if I'm wrong, but we're going to do that after the second shock, correct? And
Correct.
VFib.
So the first 2 shocks are regular shocks, and then on the 3rd shock, it's double sequential.
So when we produced a vector change video, we showed you exclusively where to be putting those pads. So remember, the first unit on scene, we're going to do anterior, posterior. The second unit on scene, go ahead and put that anterior lateral placement, and then on that 3rd shock, we're going to do double sequential right at the same time.
And when you say double sequential, it's usually within a second, usually a millisecond. So, I mean, you can hit them at the same time. You can hit it like right after, but most of the studies look at it that there's like a split second in between that, and it prevents a little bit of monitor feedback when that happens. The other thing we're going to highlight, just to reiterate our fire transport policy, talk about diltiazem or lack thereof. We're going to move into hemorrhagic shock and separate modules for that, open fractures, and then finally talk about needle chest decompression. So just to reiterate, for fire transport, if we transport, we're not a licensed ambulance service, so we have to notify the state of any patient that gets transported. If there's no available ETA or no available ambulance, or if they're advising an ETA more than 30 minutes and you have a critical patient, then obviously that's a patient that's eligible for transport in one of our transport capable rescues. Basically, the patient has to have a critical or some sort of time sensitive problem, a cardiac arrest, a stroke, things like that. And as Chief Adams has pointed out, if you transport a patient and you end up on the wall, you've transported the wrong patient. Just remember that any of these patients that you transport, the battalion chief needs to be notified, and the whole command staff gets notified of a transport. So diltiazem, we put this on the trucks, the ALS units during COVID, I believe, if I'm not mistaken, mainly because of response times. We use it for atrial fibrillation with rapid ventricular response. Unfortunately, it's very difficult to obtain. A lot of it is back ordered. A lot of the supplies require refrigeration, which we get around that with a specific type of diltiazem that we carry, and that is very difficult to obtain. We've not used it very much since we've put it on there, so we've made the decision that we're going to pull it off the trucks as it expires or it gets used. We are looking at some alternatives, and mainly it's metoprolol or low pressor. We're looking at going with it. Usually it's 5 milligrams every 5 minutes for 3 doses, and we'll give you a protocol on that once we secure it. It has better shelf life, it's cheaper, it's readily available, and it's less complicated to administer. Particularly if you're getting into diltiazem infusions, you really need that on a pump, and that's something that we don't carry here. So here in the future, in the next few months, you'll be seeing a video about metoprolol, and hopefully we'll be carrying it.
So just to reiterate, cardizem's coming off the truck. We're also going to be pulling atropine 8 milligrams off the truck. The megadose atropines are all coming off too, except for people from MedOps, since they support the hazmat team.
Right, right. One of the modules we're going to present is about hemorrhagic shock. We're very excited that probably 2 years in the making that we're getting blood products initially coming to MedOps. Depending on the success of that, may expand out to other units. It's in the final phases with legal finalizing the contract with our vendor. Unfortunately, we won't be getting whole blood just because of the shelf limitations and it's very difficult to obtain whole blood. We will be getting 2 units of packed red blood cells and 2 units of fresh frozen plasma. So basically it's 2 units of whole blood minus the platelets.
Okay.
So we'll be getting that on the MedOps truck, and MedOps will be responding to high-risk MVCs and things where blood may be necessary. We are also expanding TXA. MedOps has been carrying it, I think, for about 4 or 5 years now.
Yes,
We're going to
sir.
expand that to all ALS units. So we'll talk about that here in a few minutes. Open fractures, we're developing a surgical emergency response team, and one of the things for that is that we carry Rocephin or ceftriaxone for an antibiotic. There's plenty of data that patients that have open fractures that get antibiotics earlier, they tend to have less infection, and infection can have some really bad outcomes if you get an infected open fracture because you end up with an amputation. So we're going to expand ceftriaxone to all units when we place it on there. On the MedOps team, and basically we're going to use it for open fractures, and we'll talk about that here in a few minutes.
So a couple other little highlights I want to hit, Doc, is the SAM pelvic sling. Let's start with that first. Something everybody's got to be aware. We know we're coming out. Every piece of apparatus should have it. Just realize they did the new packaging. When you guys get it, at the top, it's going to actually tell you the size. And it's very, very small letters, and I'll actually say this is a large. As you notice, this little sticker, it can come off. What you need to do is pull your insert out, and like I did already, circle large. So that way in the heat of the moment, you're not like trying to read, is this a standard or a large?
Or if you forget your reading glasses.
Or you forget your reading glasses. But everybody has 2 sizes. We do have the standard and large. Let's talk about when we should use this.
So basically for somebody with hemorrhagic shock, or impending hemorrhagic shock that has pelvic fractures. Not really hip fractures, because the way that it binds around, it can actually displace some of the hip fractures and actually increase pain. Most of your hip fractures aren't going to bleed that much from it. It's usually the pelvic fracture. So you're really looking for that open book pelvis where the pelvis gets separated, the rings get separated, because by using the binder, you bring those together and it kind of the veins get stretched as an open book pelvis happens. So it kind of brings the veins back together just a little bit. So
Almost
that way
tamponading them.
Correct, and it helps with the bleeding in that situation.
So we're talking about if I'm doing an assessment, I'm pushing down and then in. If I got down crunchiness, in crunchiness, hey, KISS, I'm going to go for the pelvic spline. And we did do a training video on this the first time. The biggest key is making sure you have the proper landmarks here.
Right.
This is not a weightlifter's belt. You've got to find the proper landmarks and then do it that way.
Correct.
Something else I'm excited about coming out is unfortunately, we ran a bunch of pediatric arrests this year. Sometimes they're hard to intubate. And so what we've done is now we've gone to 2 different eye gels for pediatric. So we've got a size 2 and a 2.5. And they're the tiny little baby eye gels. So at least if you can intubate, because intubation is golden standard, but if you can't intubate, at least we've got you coming to the ALS stations only, no BLS, but the ALS stations will actually have the pediatric eye gels. And Doc, I got to ask you,
What's that?
you got something in your pocket? You happy? You happy to see me?
Oh no, that's just a bougie. I'm sorry.
Oh, bougies! We got bougies, everybody. Bougies are coming out. We're going to have some good training on this. ACLS. Also, feel free to call me out, but this right here is a lifesaver for those super difficult intubations. Do you use it a bunch in the ER?
We use it sometimes. I think if you combine that with the video laryngoscopes, I don't think there will be an airway that you'll ever miss.
I have to agree with you. And like I said, I'll show you a couple KISS principles, either coming out or during ACLS, on how I utilize the bougies. So, the last thing I want to mention, everybody, YouTube. If you go to Cobb Fire On Demand Training, I'm on the YouTube site, but you go to Cobb Fire On Demand Training, we have all the EMS videos on there. The SAM pelvic sling is in there. Also, we have the heating blankets, because remember we talked about earlier the trimordial death, and so that way they're on all the apparatuses, so somebody's got to remember trauma. We're doing this TXA now, MedOps is on scene, we're starting to do the blood products. Eventually, hopefully, fingers crossed, we can spread that throughout maybe a north and south station also, so it could be going to other stations. But we have every training video we've ever done, everything on the Zoll, everything. So even on one of the Zoll videos, we actually talk about shock index. So once again, something easy to come back with the TXA. Just remember, when you guys are en route to any type of call, you've got your hand heavy on the iPad, you've got it on your phone. If you have trouble, I've done a hand heavy video to help you relearn hand heavy. All those protocols and procedures are there just in case you forget the decompression or something. The SAM Thoracyte's on there, somebody can look at it en route. And then of course the training videos when you guys get back, if you forget anything about the Zoll monitor, the heating blanket, whatever, they're all on there. utilize your resources.
The Hand Heavy app's a great resource. I'm glad that we went with that.
Oh, it's a no-brainer. It takes everything out. Remember how we used to do the long piece of tape to write pounds to kilograms? Now I got mLs, milligrams, so no-brainer. Well, Doc, thank you once again for a fabulous
Thank you
clinical
for having
update.
me over.
And once again, you guys, if you need anything, reach out to myself or the training division. I will happily come out to your station and reteach you anything.